Welcome to this video entitled, Effect of Lipid Management on Coronary Heart Disease Risk in Patients with Diabetes. We will begin with an overview. This chapter describes strategies for and effects of therapeutic lifestyle changes and/or pharmacologic interventions with lipid-lowering medications on coronary heart disease, abbreviated as CHD, risk in patients with diabetes mellitus, abbreviated as DM, focusing on the most recent data from randomized clinical trials in the context of contemporary clinical care. Planning a strategy to manage dyslipidemia for coronary heart disease risk reduction for patients with diabetes mellitus can be partitioned into 5 steps. 1. Identifying lipid-related risk factors for coronary heart disease, including those related to unhealthy lifestyle behaviors. 2. Assessing and then stratifying coronary heart disease risk. 3. Determining which among these risk factors are modifiable through interventions affecting lifestyle combined with timely and appropriate medications. 4. Confirming effectiveness of various lipid interventions on coronary heart disease outcome reduction in clinical trials. And 5. Translating the expected gains to common, unselected diabetes mellitus patients most likely to benefit from these interventions. We will now discuss coronary heart disease risk among patients with diabetes mellitus and dyslipidemia. To better understand coronary heart disease risk for patients with versus without diabetes mellitus in the context of lipid management, it is informative to analyze baseline characteristics of diabetes mellitus patients participating in landmark lipid-lowering clinical trials such as trials focused exclusively on patients with diabetes mellitus, or those that report data on a sufficient number of patients making up diabetes mellitus subgroups. For the present summary, data were considered from trials with a high proportion of patients with diabetes mellitus at baseline, that is greater than 15%, and/or trials that enrolled at least 100 patients with prevalent diabetes mellitus. Data from 47 lipid trials comprising 198,930 patients, of whom 65,558 had prevalent DM, are summarized in tables 15.1, alphabetically by trial name acronym, and 15-2, ordered by descending numbers of participants with diabetes mellitus, with abbreviations used to describe respective trial outcomes defined in Table 15.3. Except for the Acute Coronary Syndrome Israeli Survey, abbreviated as ACSIS, all studies were randomized controlled trials, most of which evaluated monotherapy with a statin or a fibrate versus placebo. A few randomized controlled trials studied a combined lipid-lowering intervention, statin plus fibrate, statin plus ezetimibe. STENO2 was a randomized comparison of a multifactorial intervention versus usual care, with statins and/or fibrates used as part of a comprehensive global cardiovascular disease, abbreviated as CVD, risk intervention strategy in patients with diabetes mellitus and albuminuria. The baseline characteristics of patients participating in clinical trials and sub-studies that included only patients with diabetes mellitus, N equals 46,326 patients, are described in Table 15.4, and ranked by baseline low-density lipoprotein, LDL, cholesterol, LDL-C. Mean age at entry was 60.3 years and, similar to lipid intervention trials not focusing specifically on diabetes mellitus, men accounted for more than 2/3 of the patients. Most diabetes mellitus patients in these studies are assumed to have had type 2 diabetes mellitus, T2DM, given the relative prevalence of T2DM versus type 1 diabetes mellitus, T1DM, in the age groups studied, with a few trials specifically allowing inclusion of patients with T1DM, and most trials not differentiating diabetes mellitus type for eligibility. Average baseline lipid levels in the trials surveyed did not meet contemporary targets for lipid management in diabetes mellitus patients. See later. With mean LDL-C 129 mg per deciliter, that is, 3.3 millimoles per liter, non-high-density lipoprotein, HDL, cholesterol, non-HDL-C, 166 mg per deciliter, 4.3 millimoles per liter, HDL-C 42 mg per deciliter, 1.1 millimoles per liter, and triglycerides, TGs, triacylglycerols, 180 mg per deciliter, 2 millimoles per liter. In most diabetes trials and diabetes mellitus subgroup analyses, LDL-C was calculated, with routine direct measurement in only 3 studies: 4D, HPS-MRC, BHF, diabetes mellitus subgroup, and proactive. Mean baseline apolipoprotein B100, ApoB, concentration was 115 mg per deciliter, a value also beyond generally accepted targets, as inferred from studies in which baseline ApoB level was available in the reports. In addition to elevated and/or unsatisfactory LDL-C levels at study entry, the frequent findings of low HDL-C together with elevated fasting triglycerides are consistent with the assumption of a high prevalence of atherogenic dyslipidemia in these diabetes mellitus patients at enrollment. See Table 15.4 and Chapter 10. Similarly, data from studies in which baseline ApoB was measured concomitantly with LDL-C reveal a high prevalence of increased small, dense LDL particles, a pattern commonly observed in type 2 diabetes mellitus. Given the high cardiovascular (CV) risk associated with diabetes mellitus, observed event rates in reported lipid trials are influenced by the proportion of patients with diabetes mellitus enrolled. The rates of primary CV outcome events among patients with diabetes mellitus across lipid intervention trials in primary prevention, secondary prevention, and post-acute coronary syndrome (ACS) patient populations are summarized in Table 15.5, arranged by decreasing hazard, with significantly higher rates among those with versus without diabetes mellitus across the spectrum of clinical indication. To estimate coronary heart disease risk or to better characterize it for specific patients groups, there are other complementary determinations in addition to total cholesterol and LDL-C levels measurements. Non-HDL-C, ApoB, and LDL particle, abbreviated as LDLP, concentration are closely associated with obesity, diabetes mellitus, insulin resistance or hyperinsulinemia, and other markers of dysmetabolism in conditions of increased cardiometabolic risk, such as type 2 diabetes mellitus. Their determination, in addition to LDL-C measurement, may provide information before and after introduction of lipid-lowering therapies to assess cardiovascular risk at baseline and residual vascular risk after intervention. Compared with on-treatment LDL-C, these may help to clarify some aspects of risk and response to therapy, but their combined measurement is not routinely recommended in diabetes mellitus. In addition to non-HDL-C, ApoB, and LDLP determination, screening for atherogenic dyslipidemia before any lipid-lowering intervention is an easy and inexpensive means to determine residual vascular risk associated with low HDL-C, high triglycerides, and their determinants. As a result of lack of agreement on cutoffs for HDL-C and triglycerides, this is rarely performed in routine practice. An alternative approach to defining atherogenic dyslipidemia as the combined occurrence of high triglyceride levels plus low HDL-C uses the ratio of triglyceride to HDL-C. Because both TG and HDL-C levels are continuous risk variables with mutually additive associations with residual vascular risk, computing a ratio of fasting triglycerides to HDL-C provides a summary metric for the severity of atherogenic dyslipidemia, calibrated as a continuous rather than a dichotomous variable. Given the extreme right skewness of TG values, assessing atherogenic dyslipidemia using log triglycerides over HDL-C may be more clinically informative than an untransformed ratio. Pause the video and carefully scrutinize Table 15.1 summarizing trials on lipid management of coronary heart disease risk before advancing to the next slide. Pause the video and carefully scrutinize Table 15.1 summarizing trials on lipid management of coronary heart disease risk before advancing to the next slide. Pause the video and carefully scrutinize Table 15.2 summarizing trials of lipid-lowering therapy by numbers of diabetic patients at inclusion before advancing to the next slide. Pause the video and carefully scrutinize Table 15.2 summarizing trials of lipid-lowering therapy by numbers of diabetic patients at inclusion before advancing to the next slide. Pause the video and carefully scrutinize Table 15.2 summarizing trials of lipid-lowering therapy by numbers of diabetic patients at inclusion before advancing to the next slide. Pause the video and carefully scrutinize Table 15.3 summarizing outcomes classification before advancing to the next slide. Pause the video and carefully scrutinize Table 15.4 summarizing baseline characteristics of diabetes trials and sub-studies ranked by low-density lipoprotein cholesterol at inclusion before advancing to the next slide. Pause the video and carefully scrutinize Table 15.5 summarizing primary outcome rates, in the comparator arm, baseline atherogenic lipids, and ApoB from lipid-lowering trials before advancing to the next slide. Next we will discuss lipid management strategies to reduce cardiovascular risk. Let's begin with therapeutic lifestyle changes. The cardiometabolic abnormalities underlying coronary heart disease risk in type 2 diabetes mellitus and their potentially reversible components under the influence of various therapeutic lifestyle changes make the population with these abnormalities particularly suitable to respond positively to such interventions, provided they are applied early, i.e., in primary prevention, and maintained long-term. Long-term compliance with therapeutic lifestyle changes must be optimized and regularly assessed and reinforced, because it is often difficult for patients with diabetes mellitus to comply long-term with dietary and lifestyle advice. This is all the more relevant because the hallmark of atherogenic dyslipidemia, low HDL-C and high triglycerides, and all three other defining components of the metabolic syndrome are responsive to therapeutic lifestyle changes. Lifestyle approaches and dietary strategies to lower LDL-C and TGs and raise HDL-C, as well as the effects of dietary carbohydrate restriction on atherogenic dyslipidemia, fatty acid partitioning, and metabolic syndrome have been previously reviewed. The American Diabetes Association, ADA, recommends that diabetes mellitus patients on low-carbohydrate diets undergo lipid profile monitoring and that the ratios of dietary intake of carbohydrates, proteins, and fat be individually adjusted to the metabolic requirements and preferences of patients. With regard to dietary intake of saturated and trans-saturated fatty acids, both modulators of LDL-C levels, there are no specific data available for patients with diabetes mellitus, and recommended dietary goals for diabetes mellitus patients are currently those, by default, of individuals with established coronary heart disease. Thus, saturated fat intake should not exceed 7% of total calories, and intake of trans-saturated fatty acids should be reduced. Unfortunately, for most type 2 diabetes mellitus patients in real-life conditions, it is very hard to follow the current recommendations regarding dietary and physical activity for diabetes mellitus for the long term and/or with the required intensity. This underscores the importance of systems-based lifestyle interventions. Even for those who are able to implement lifestyle changes, many will not achieve sufficiently low LDL-C, non-HDL-C, and ApoB and/or improve atherogenic dyslipidemia components through therapeutic lifestyle changes alone and will require lifelong therapy with one or more lipid-lowering drugs. For example, in the Action for Health in Diabetes, abbreviated as Look Ahead, trial, 5,145 overweight or obese adults with type 2 diabetes mellitus were randomized to intensive lifestyle intervention focusing on weight loss and increased leisure time physical activity versus standard care diabetes mellitus support and education. Despite greater and sustained weight loss, greater reductions in glycated hemoglobin, and improvements in fitness in the intensive lifestyle arm, there was no difference achieved between the groups in LDL-C. The overall trial failed to demonstrate mortality improvement, as discussed in Chapter 12. Pause the video and carefully scrutinize Figure 15.1 illustrating sites of action of lipid-modifying drugs before advancing to the next slide. We will now discuss drugs targeting low-density lipoprotein cholesterol. Given the predominant role of LDL-C as the major lipid-related modifiable risk factor for coronary heart disease in non-diabetic and diabetic patients, most of the pivotal studies have investigated the benefit on coronary heart disease outcomes of pharmacologic agents whose main effect is to reduce LDL-C levels, as shown in Figure 15.1. Most of the clinical evidence of a beneficial effect on coronary heart disease of a decrease in total cholesterol and/or LDL-C was derived from landmark clinical trials with statins in non-diabetic and diabetic cohorts. In contrast, it is currently not established whether other non-statin drugs specifically targeting LDL-C, ezetimibe, bile acid binders, proprotein convertase subtilisin, Kexin type 9, PCSK9, inhibitors, as shown in Figure 15.2, or with an LDL-C lowering component among other lipid and lipoprotein modulating effects, niacin, fibrates, have a beneficial influence on cardiovascular events in non-diabetic or diabetic patients. Pause the video and carefully scrutinize Figure 5.2 illustrating PCSK9 inhibition before advancing to the next slide. Pause the video and carefully scrutinize Figure 5.3 illustrating the mechanism of action of statins before advancing to the next slide. 3-hydroxy-3-methylglutaryl coenzyme A, abbreviated as HMG coenzyme A, reductase inhibitors. The statins inhibit the 3-hydroxy-3-methylglutaryl coenzyme A, HMG coenzyme A, reductase, upregulating hepatic expression of LDL receptors and increasing uptake of circulating LDL, as shown in Figure 15.3, and thereby decreasing circulating cholesterol, total cholesterol, LDL-C, and non-HDL-C, as a result of lowered LDL-P numbers. As a direct consequence, statins also reduce levels of ApoB, the major atherogenic apolipoprotein, of which a single structural molecule is present on each LDL-P, as well as on each of the triglyceride-rich lipoprotein precursors, very low-density lipoproteins, abbreviated as VLDLs, intermediate-density lipoproteins, IDL, and VLDL remnants. In general, patients with and without diabetes respond similarly to statins with regard to LDL-C reduction, with response similarly dependent on drug choice, dose choice, and individual response. Proportional reductions in LDL-C levels on statin treatment range from 20% to 40% for less potent statins, fluvastatin, lovastatin, and pravastatin, 30% to 45% for simvastatin, and 40% to more than 50% for the most potent statins, atorvastatin, rosuvastatin, and pitavastatin. In the vast majority of diabetic and non-diabetic patients, long-term statin use is safe and effective. Next we will discuss patients with diabetes in key statin trials. Numerous studies have demonstrated the effectiveness of statins to reduce primary coronary heart disease outcomes in primary and secondary prevention settings and post-acute coronary syndrome events. The risk reduction after LDL-C lowering parallels the magnitude of the achieved LDL-C decrease in populations with and without diabetes. The studies having established the beneficial effect of statins on coronary heart disease risk in patients with diabetes mellitus selected for the present review comprised a total of 20,103 diabetes mellitus patients, followed for a mean duration of 4 years. Average, 1 standard deviation, on treatment LDL-C decreased to a mean 81, standard deviation 18, milligrams per deciliter, 2.1, standard deviation 0.5, millimoles per liter. This corresponds to absolute and relative reductions of 48 milligrams per deciliter, 1.2 millimoles per liter, and 36%, respectively. With respect to non-LDL lipids, mean on statin HDL-C was 46.4 milligrams per deciliter, 1.2, 0.1 millimoles per liter. Non-HDL-C was 114.19 milligrams per deciliter, 0.5 millimoles per liter, and triglyceride was 144.12 milligrams per deciliter, 1.6, 0.1 millimoles per liter, as shown in Table 15.6. In the active arms of statin trials, N equals 10,077, a total of 1638 primary outcome events, 5.3% per year, were observed, versus 2022 outcomes, 7% per year. In the comparator arms, N equals 10,026, with a weighted and adjusted hazard ratio of 0.76, 95% confidence interval of 0.65 to 0.84, favoring statin treatment. As a class, for each 1 mg per deciliter, 0.03 millimole per liter, reduction in LDL-C achieved on statin, the hazard ratio of incident coronary heart disease was reduced on average by 0.5%. This translated into a 19.5% primary outcome reduction for every 1 millimole per liter, that is 40 milligrams per deciliter, decrease of LDL-C. The mean absolute risk reduction for composite major adverse cardiovascular events in statin trials was 6%. The mean relative risk reduction was 25%. The average number needed to treat for 5 years to prevent one major adverse cardiovascular event was 16 patients. Qualitatively similar effects are evident when analyzing the component endpoints of all-cause mortality. Hazard ratio 0.88, 95% confidence interval of 0.65 to 1.01, and fatal coronary heart disease events, hazard ratio 0.59, 95% confidence interval of 0.48 to 0.97. Although pooled analysis of death alone failed to achieve statistical significance. See Table 15.6. We will now progress to meta-analyses of statin efficacy among diabetes mellitus patients. In the Cholesterol Treatment Trialists Collaboration, abbreviated as CTT, prospective meta-analysis of data from 90,056 participants in 14 statin randomized controlled trials, among whom 21% had diabetes mellitus. Statin therapy safely reduced 5-year incidence of major adverse coronary events, abbreviated as MACEs, and coronary revascularization by approximately 20% per 40 mg per deciliter, corresponding to 1 millimoles per deciliter, LDL-C reduction, and largely independent of baseline LDL-C. Other meta-analyses have confirmed these observations that statins effectively reduce coronary heart disease outcomes with or without diabetes mellitus in both primary and secondary prevention populations, including meta-analyses focused only on statin efficacy among diabetes mellitus participants. Patients with diabetes mellitus could possibly benefit even more from the cardioprotective effects of statins than those without diabetes mellitus, and the authors of the CTT meta-analysis of 18,686 diabetic patients from 14 randomized controlled trials went as far as to recommend considering statin therapy for all patients with diabetes mellitus and elevated risk for incident cardiovascular events, based on the 21% proportional reduction in major adverse coronary event for every 40 mg per deciliter, corresponding to 1 millimoles per deciliter, LDL-C reduction. However, this may overestimate statin efficacy to some degree because of the exclusion from the analyses of data from the ASPEN trial, which was a diabetes mellitus-specific trial of atorvastatin that failed to demonstrate statistically significant differences in cardiovascular outcomes. Pause the video and carefully scrutinize Table 15.6 statins' effects on lipids and ApoB and primary outcome, ranked by low-density lipoprotein cholesterol, abbreviated as LDL-C, reduction, in diabetes mellitus trials and sub-studies before advancing to the next slide. Next we will discuss statin use, glucose homeostasis, and new-onset diabetes mellitus. Much has been discussed with regard to cholesterol metabolism, use of statins, and drug-induced pancreatic beta cell dysfunction, with a modest diabetogenic action of statins increasingly considered an infrequent, likely dose-dependent side effect affecting most of the drugs within the class. Incident diabetes cases observed in randomized controlled statin trials have been reported and included in meta-analysis of data from 8 landmark trials, such as A to Z, ASCOT-LLA, GREACE, HPSMRC, BHF, IDEAL, Jupiter, SPARCL, TNT. On a population basis, statins may cause marginal increases in blood glucose, both fasting and postprandial, in predisposed individuals. This translates into a slight increase in glycated hemoglobin A1c, and for patients with baseline values just below diagnostic thresholds leads to a small excess in incident diabetes mellitus cases for statin versus control patients. In most patients with small increases in glycated hemoglobin A1c, this observation is of uncertain clinical relevance. For patients already diagnosed with diabetes mellitus, subtle deterioration of glycemic control and/or a rise in glycated hemoglobin A1c, if it occurs, appear equally modest, even verging on the trivial when put into perspective with the cumulative rise in blood glucose over years associated with the relentless loss of residual beta cell function. Because major randomized controlled trials investigate very large numbers of patients, such an effect, however small, may produce highly significant statistics, despite limited clinical relevance. Indeed, the ratio between number needed to treat, to avoid occurrence of one major coronary heart disease event, versus number needed to harm, i.e., new-onset diabetes mellitus or glucose control worsening in patients with already known type 2 diabetes mellitus, remains unquestionably in favor of using statins to lower LDL-C, whatever a patient's glucose homeostasis at the time of statin initiation, an opinion underpinned by the recent American College of Cardiology, abbreviated as ACC, American Heart Association, abbreviated as AHA, and the European Society of Cardiology, abbreviated as ESC, cholesterol treatment guidelines. We will now focus on ezetimibe. Ezetimibe is a selective blocker of intestinal cholesterol absorption, which binds to Niemann-Pick C1-like 1, NPC1L1, receptors in the gut, Fig. 15-4. Whereas ezetimibe monotherapy moderately lowers LDL-C, below 20%, it markedly reduces it when co-administered with a statin. Ezetimibe counteracts, in a complementary manner, the intestinal absorption of cholesterol that is often upregulated by statins. This upregulation reduces the LDL-C lowering effectiveness of statins in patients with high intestinal ability to reabsorb cholesterol from the intestinal lumen whenever hepatic synthesis is constrained by statin inhibition of HMG coenzyme A reductase. Combination therapy with statin plus ezetimibe may represent an alternative approach to further reduce LDL-C when statin monotherapy is insufficient to lower LDL-C to target levels, as confirmed in a lipid-lowering efficacy meta-analysis. With regard to coronary heart disease outcomes data, the clinical evidence for benefit of ezetimibe is currently limited. In the SHARP trial, 9,270 patients with advanced renal disease, among whom 23% had diabetes at inclusion, were randomly assigned to treatment with simvastatin 20 mg plus ezetimibe 10 mg daily versus matching placebo with mean trial follow-up of 4.9 years. There was a significant reduction in major atherosclerotic events, coronary death, myocardial infarction, ischemic stroke, or any revascularization procedure, in the simvastatin ezetimibe group versus placebo, with a hazard ratio of 0.84, with a 95% confidence interval of 0.74 to 0.94, with a p-value equal to 0.0021. With a number needed to treat for 5 years of 47 patients. In SHARP, the treatment response in the subgroup of patients with diabetes mellitus did not differ from the findings of the overall trial. However, it remains unclear as to what extent each of the lipid-lowering drugs that were combined contributed to the results. IMPROVE-IT is ongoing and is comparing the effects of a combination of simvastatin, 40 mg, plus ezetimibe, 10 mg, daily versus simvastatin, 40 mg, alone in 18,000 very high-risk patients with acute coronary syndrome, among whom a large subgroup, that is 22%, had diabetes mellitus at enrollment. The Arbiter 6 halts trial, Arterial Biology for the investigation of the treatment effects of reducing cholesterol 6 HDL and LDL treatment strategies in atherosclerosis, investigated, in an open-label design, the effect of ezetimibe, dosed at 10 mg, versus extended-release, niacin, dosed at 2000 mg daily in 315 patients with coronary heart disease or coronary heart disease equivalent, among whom 40% had diabetes mellitus at inclusion, given on top of background statin therapy. The trial was terminated early on the basis of a pre-specified interim analysis showing superiority of niacin over ezetimibe on carotid artery intima media thickness regression, with a p-value less than 0.001. It should be noted that the study design, by isolating niacin's additional actions on HDL-C and triglycerides from its LDL-C lowering effects, could have disadvantaged detection of a beneficial effect of long-term ezetimibe therapy. Thus, part of atherosclerosis regression in the niacin arm could theoretically be ascribed to changes in components of atherogenic dyslipidemia. Given the high proportion of patients with diabetes mellitus in Arbiter 6 halts trial, a specific analysis of the respective benefits of these two lipid-lowering approaches in these patients would be of great interest. At the time of writing this chapter, no definitive data either support or call into question the effectiveness of ezetimibe, alone or in combination with statins, to reduce coronary heart disease events in patients with diabetes mellitus. We will now discuss drugs targeting high-density lipoprotein cholesterol. Given the epidemiologic evidence of a link between a low HDL-C level, or a decreased number of HDL, and increased coronary heart disease risk in non-diabetic and diabetic populations, it was logical to target HDL-C levels and/or the number of HDL particles as lipid-related modifiable cardiovascular risk factors in diabetes mellitus patients. However, several classes of drugs that alter HDL-C levels and/or function have failed to yield significant improvements in cardiovascular risk, as described in the following section. And although treatment with fibric acid derivatives, also called fibrates, does have a modest effect on raising HDL-C, their principal mechanism of action modulates circulating triglyceride levels, and therefore this class of medications will be reviewed in the following section on triglycerides. Pause the video and carefully scrutinize Figure 15.4 illustrates ezetimibe mechanism of action before advancing to the next slide. Pause the video and carefully scrutinize Figure 15.5 illustrates niacin, that is nicotinic acid, mechanisms of action before advancing to the next slide. We will now discuss niacin. Niacin, that is nicotinic acid, is a broad-spectrum lipid-altering drug with multiple effects on lipids and lipoproteins. In hepatocytes, niacin inhibits microsomal diacylglycerol acyltransferase 2, abbreviated as DGAT2, resulting in decreased triglyceride synthesis, lowered VLDL assembly, and increased intrahepatic ApoB degradation, as shown in Figure 15.5. Niacin impairs ApoB and VLDL secretion, decreases triglyceride, ApoB, non-HDL-C, LDL-C, and lipoprotein levels, and also reduces the number of VLDL, especially triglyceride-rich VLDL, and small dense LDLPs. Niacin also decreases liver fractional catabolism of ApoAI-HDL, increasing the levels of ApoAI and HDL-C, and raising type 2 HDL number. In adipose tissue, niacin modulates triglyceride lipolysis and fatty acid mobilization. The range of niacin's lipid effects theoretically means that it could be a choice drug to treat LDL-C and/or atherogenic dyslipidemia in diabetes mellitus patients with low HDL-C, elevated small dense LDL particles, and/or hypertriglyceridemia. Niacin use, especially at the beginning of treatment, often causes vasocutaneous flushing, whereas chronic niacin intake may impair insulin sensitivity, causing diabetes mellitus in some patients and, in those with diabetes mellitus, adversely influencing glucose control. To mitigate flushing, formulations of niacin or a fixed-dose combination of niacin with lirapoprant, an anti-flush pharmacologic agent, have been introduced. However, recent large clinical trials of these formulations have failed to demonstrate reduction in cardiovascular risk, with the clinical benefit suggested in earlier studies challenged by small sample sizes and high dropout rates as a result of flushing. We will now look at a few niacin clinical trial results. In the Coronary Drug Project, abbreviated as CDP, a trial comprising 3,908 men with a history of myocardial infarction, with mean study follow-up of 6.2 years, there was a significant reduction in the primary outcome, all-cause mortality, with niacin, dosed at 3,000 mg daily versus placebo. Of note, the beneficial effect became evident only years after the end of the study. Whereas the prevalence of diabetes at enrollment was not reported, the benefits of niacin were observed irrespective of the presence of impaired fasting glucose, diabetes mellitus, and/or a metabolic syndrome at inclusion. In the Stockholm Ischemic Heart Disease Study, conducted in 555 patients with a history of myocardial infarction over a mean follow-up of 5 years, there was a significant reduction in total mortality, hazard ratio 0.74, with a p-value equal to 0.05, and coronary heart disease mortality, hazard ratio 0.64, with a p-value less than 0.01, with niacin, dosed at 3,000 mg, plus clofibert, dosed at 2,000 mg, daily versus placebo. In the HDL atherosclerosis treatment study, abbreviated as HATS, conducted in 160 patients with coronary heart disease, low HDL-C, and normal LDL-C, among whom 16% had diabetes mellitus at inclusion, over a mean follow-up of 3 years, the risk of the composite primary endpoint, coronary heart disease death, myocardial infarction, stroke, revascularization for ischemic symptoms, was 90% lower, with a p-value equal to 0.03, with a combination of niacin, dosed at 2,000 to 4,000 mg, plus simvastatin, dosed at 10 to 20 mg, daily versus placebo. As summarized earlier, the Arbiter 6 Halts trial compared the addition of ezetimibe, 10 mg versus niacin, 2,000 mg daily in 315 patients, of whom 40% had diabetes, with coronary heart disease or coronary heart disease equivalent, given on top of background statin therapy. The trial was terminated early based on a pre-specified interim analysis showing superiority of niacin over ezetimibe on carotid artery intima media thickness regression, with a p-value equal to 0.001. The atherothrombosis intervention in metabolic syndrome with low HDL, high triglycerides, impact on global health outcomes, abbreviated as AIM-HIGH, trial was conducted in 3,414 patients with prior cardiovascular disease, among whom 34% had diabetes mellitus and 80% a metabolic syndrome at inclusion. The trial was interrupted early because of futility after a mean follow-up of 3 years at the time of termination. There was no benefit of niacin, dosed at 1500 to 2000 mg daily versus placebo, given in addition to standardized background LDL-C lowering therapy with simvastatin 40 to 80 mg plus or minus ezetimibe 10 mg daily to maintain LDL-C levels at 40 to 80 mg per deciliter, equivalent to 1.03 to 2.07 millimoles per liter. Whereas the primary composite outcome of coronary heart disease death, myocardial infarction, acute coronary syndrome, ischemic stroke, and/or symptom-driven revascularization was not reduced, hazard ratio 1.02, with a 95% confidence interval of 0.87 to 1.21, with a p-value equal to 0.8. Broad-spectrum improvements in lipids and lipoproteins, increased HDL-C, decreased triglyceride, and lowered LDL-C were recorded after addition of niacin. Of interest, there were no significant interactions with respect to primary endpoint occurrence according to presence or absence of diabetes mellitus at inclusion. However, a post-hoc analysis found a 36% relative reduction of the primary outcome, with a p-value equal to 0.032, in a subgroup of 439 patients with marked atherogenic dyslipidemia, defined as triglycerides equal to or greater than 200 mg per deciliter, that is equal to or greater than 2.3 millimoles per liter, and HDL-C less than 32 mg per deciliter, that is less than 0.83 millimole per liter. In HPS-2 Thrive, the risk of the composite primary endpoint, non-fatal myocardial infarction or coronary heart disease death, stroke or non-coronary revascularization, was not significantly different among 25,673 patients with either myocardial infarction or cerebrovascular disease or peripheral arterial disease, or with diabetes mellitus plus coronary heart disease, the latter amounting to 32% of enrolled patients, randomized to niacin plus liraglutide, dosed at 2000 mg plus 40 mg, or placebo over a median follow-up of 3.9 years, given in addition to standardized background LDL-C lowering therapy, simvastatin 40 mg, ezetimibe 10 mg daily, to maintain a total cholesterol target of 135 mg per deciliter, 3.5 millimoles per liter. There were, on the other hand, significant increases with niacin plus liraglutide in diabetic complications, hazard ratio 1.55, with a 95% confidence interval of 1.34 to 1.78, with a p-value less than 0.0001. New onset diabetes mellitus, hazard ratio 1.27. with a 95% confidence interval of 1.14 to 1.41, with a p-value less than 0.0001, and other side effects, infection, gastrointestinal effects, musculoskeletal, bleeding, and skin adverse events. In a systematic meta-regression review of 9,959 patients treated with niacin to reduce cardiovascular disease, a significant reduction in incidence of the composite endpoints of any cardiovascular events was reported, hazard ratio 0.75, with a 95% confidence interval of 0.59 to 0.96. with a p-value equal to 0.02, irrespective of on-treatment HDL-C changes. In the setting of subpopulations with diabetes mellitus, As for ezetimibe, a formal demonstration of the effectiveness of niacin, niacin, or niacin, liraglutide, alone or in combination with statins, to reduce coronary heart disease events is not currently available. Based on the negative results of these most recent large-scale clinical outcomes trials of niacin preparations, in 2013 the European Medicines Agency, abbreviated as EMA, recommended that the marketing, supply, and authorization of 3 identical niacin plus liraglutide products for the treatment of adults with dyslipidemia be suspended across the European Union. None of the formulations had been approved for use in the United States. Next we will discuss cholesterol ester transfer protein inhibition. Cholesterol ester transfer protein, abbreviated as CETP, mediates intravascular transfer and exchange of cholesterol ester and triglyceride between triglyceride-rich lipoproteins and their remnants, and HDL. An antiatherogenic potential has been suggested on the basis of a considerable rise in HDL-C, combined with a substantial decrease in LDL-C, lipoprotein A, and ApoB levels after pharmacologic inhibition of CETP. Clinical results for the first 2 CETP inhibitors were, however, problematic. Torcetrapib development was stopped because of higher rates of cardiovascular events and mortality in the investigation of lipid level management to understand its impact in atherosclerotic events. Trial abbreviated as Illuminate, comprising 15,067 patients, of whom 44% had diabetes mellitus at inclusion. Development of the CETP inhibitor dalcetrapib was also discontinued because of ineffectiveness, based on data from the DAL outcomes trial in 15,871 acute coronary syndrome patients, 25% of whom had diabetes mellitus at baseline. Regarding other CETP inhibitors under study, there has not been any general safety issue reported in ongoing prospective outcomes studies so far. Reveal and Accelerate, a study of evacetrapib in high-risk vascular disease, are currently evaluating whether the broad range of lipid modifications induced by CETP inhibition translate into cardiovascular risk reduction in patients with a past myocardial infarction, cerebrovascular atherosclerotic disease, peripheral arterial disease, and/or diabetes mellitus with evidence of symptomatic coronary heart disease abbreviated as REVEAL, and in patients with high-risk vascular disease, past acute coronary syndrome, cerebrovascular atherosclerotic disease, peripheral arterial disease, and/or diabetes mellitus with coronary artery disease abbreviated as Accelerate. Next we will discuss drugs targeting triglycerides. Because pharmacologic lowering of LDL-C by statins, alone or combined with ezetimibe, has minimal effects on HDL-C and triglyceride levels, atherogenic dyslipidemia remains frequent among patients treated for elevated LDL-C, even when LDL-C targets are achieved. Among the currently available medications targeting triglyceride and atherogenic dyslipidemia, fibrates, niacin, and omega-3 fatty acids are known to improve one or more lipid abnormalities characteristic of diabetes mellitus, including atherogenic dyslipidemia components. We will now discuss fibric acid derivatives, also called fibrates. Fibrates are pharmacologic agonists of PPAR-alpha, which are nuclear receptors that coordinately regulate gene transcription. Activated PPAR-alpha regulates genes involved in lipoprotein metabolism, including ApoA1 and ApoA2, HDL particle formation, lipoprotein lipase, triglyceride-rich particles lipolysis, ApoC3, decreasing triglyceride-rich particle numbers and small dense LDL particles, ApoAV, decreasing triglyceride levels, adenosine triphosphate, ATP, binding cassette transporter A1, abbreviated as ABCA1, promoting cholesterol efflux and reverse cholesterol transport, scavenger receptor B1, HDL capture and catabolism, and transrepression of nuclear factor kappa B and activator protein 1 transcription factors, anti-inflammatory and parietal vascular protection, as shown in Figure 15.6. Reported effects of fibrates on lipids and lipoproteins among diabetes mellitus patients participating in clinical outcomes trials include mean on-treatment triglyceride levels of 147, South Dakota 29, milligrams per deciliter, 1.7, corresponding to an SD 0.3 millimol per liter, with absolute and relative mean reductions of 39 mg per deciliter, 0.4 millimol per liter, and 19%, respectively. Average on-treatment LDL-C was 120, 37 mg per deciliter, 3.1, that is 1 millimol per liter, HDL-C 41, that is 5 mg per deciliter, 1.1, that is 0.1 millimol per liter, non-HDL-C 152, 43 mg per deciliter, 3.9, 1.1 millimoles per liter, and ApoB 108, 28 mg per deciliter. Most clinical trials of fibrates have included patients without and with diabetes mellitus. The diabetes mellitus subsets were most often too small for meaningful conclusions to be drawn about efficacy specifically in patients with diabetes mellitus. Two trials have evaluated the effects of fenofibrate specifically in high-risk diabetes mellitus populations. The field trial investigated the effects of fenofibrate, 200 mg per day, versus placebo in 9,795 patients with type 2 diabetes mellitus with or at risk for cardiovascular disease, with a primary composite outcome of coronary heart disease, death, or non-fatal MI. Eligibility criteria also included total cholesterol, abbreviated as TC, 116 to 251 mg per deciliter, that is 3 to 6.5 millimoles per liter, and either TC, HDL-C4 or triglycerides 89 to 443 mg per deciliter, that is 1 to 5 millimoles per liter. Over a mean follow-up of 5 years with 544 primary endpoint events occurring, differences in the primary outcome were not statistically different, hazard ratio 0.89, with a confidence interval of 0.75 to 1.05. The Accord lipid trial investigated the effects of fenofibrate, dosed at 160 mg per day, versus placebo, each added to background simvastatin therapy, in 5,518 patients with diabetes mellitus and high cardiovascular risk, with a primary composite outcome of cardiovascular death, myocardial infarction, or stroke. Over a mean follow-up of 4.7 years with 601 primary outcome events for analysis, there was no significant difference between the groups, hazard ratio 0.92, with a 95% confidence interval of 0.79 to 1.08. Although fenofibrate therapy was ineffective to reduce risk for the primary composite outcome in the overall cohort, analyses of the pre-specified subgroup, that is 17%, of patients with atherogenic dyslipidemia at inclusion, defined as fasting triglycerides greater than 204 mg per deciliter, equivalent to 2.3 millimoles per liter, and HDL-C less than 34 mg per deciliter, equivalent to less than 0.9 millimole per liter, yielded a statistically significant 31% reduction, with a p-value less than 0.05. The implications of Accord lipid are threefold. 1. Type 2 diabetes mellitus patients with atherogenic dyslipidemia have a 70% increase in relative risk for coronary heart disease compared with those without atherogenic dyslipidemia, even when LDL-C is controlled with simvastatin. 2. Addition of fenofibrate to simvastatin appears to reduce cardiovascular events, although with noted limitations of subset analyses in an overall neutral trial. And 3. Such dual therapy was well tolerated. We will now discuss general limitations of the available fibrate data. The most significant limitation of the totality of the fibrate data is the failure to limit the evaluation to patients with atherogenic dyslipidemia, with trials evaluating broad cardiovascular risk cohorts or cohorts with diabetes mellitus, with or without atherogenic dyslipidemia. This limitation is highlighted by the biologic plausibility of the atherogenic influence of high triglycerides combined with low HDL-C, the known mechanism of action of the fibrates, and sub-analyses across multiple trials consistently demonstrating efficacy of fibrates in patients with the combination of high triglycerides and low HDL-C. Thus, the fragmented amount of direct clinical evidence results from a lack of randomized clinical trials, on a large scale, comparing fibrates and statins head-to-head, or investigating the additional effect of fibrates, versus placebo, in combination therapy with statins in long-term studies that would have included only patients with high triglycerides, or atherogenic dyslipidemia, with and without diabetes mellitus. For these reasons, until further data come available, it is most appropriate to interpret the evidence to date regarding fibrate effects on coronary heart disease outcomes in light of the following: lipid characteristics at entry, including hypercholesterolemia versus non-LDL dyslipidemia and average triglyceride levels, concomitant treatment with statins at entry, or statin admission during follow-up, and cardiovascular risk of enrollees at baseline, including that related to the proportion of patients with diabetes mellitus, the latter usually with type 2 diabetes mellitus at presentation, comorbid with atherogenic dyslipidemia and/or hypertriglyceridemia. And now we will discuss omega-3 fatty acids. Oral supplementation with omega-3, N3, fatty acids, marine-derived eicosapentaenoic acid, abbreviated as EPA, and docosahexaenoic acid, abbreviated as DHA, and plant-derived alpha-linolenic acid, abbreviated as ALA, decreases hypertriglyceridemia, inhibits platelet aggregation, improves plaque stability and endothelial function, and prevents certain arrhythmias. It is on the basis of these observations that large clinical outcomes trials have been conducted to evaluate the potential benefits of these supplements on cardiovascular events and death. In the Japan eicosapentaenoic acid lipid intervention study, abbreviated as JELIS, 18,645 patients with hypercholesterolemia, among whom 16% had diabetes mellitus at inclusion, were given EPA, 1.8 gram per day, plus statin versus statin alone during a mean follow-up of 4.6 years. There was a significant reduction in the primary outcome of developing any MACE, hazard ratio 0.81. with a 95% confidence interval of 0.69 to 0.95, with a p-value equal to 0.011. In the small subgroup of patients with atherogenic dyslipidemia at enrollment, triglycerides equal to or greater than 150 mg per deciliter, corresponding to equal to or greater than 1.7 millimoles per liter, and HDL-C below 40 mg per deciliter, corresponding to below 1 millimole per liter, 5% of the total study population. N3 supplementation was associated with a significant 53% RRR. Similarly, in a sub-analysis stratified by glucose status within the first 6 months of the trial, 4,565 patients with diabetes mellitus or impaired fasting glucose had a 22%, with a p-value equal to 0.048, reduction in the primary composite event with EPA treatment. In the outcome reduction with an initial glycine intervention, Origin, trial, 12,536 patients with dysglycemia, impaired fasting glucose or glucose intolerance, that is 18%, or diabetes mellitus, that is 82%, among whom 59% had a history of myocardial infarction, stroke, or revascularization were randomized to EPA, that is 465 mg, and DHA, that is 375 mg, daily versus placebo, with the primary outcome of cardiovascular death. Over a median 6.2 years, EPA or DHA had no significant effect on the primary outcome that occurred in 1155 patients, hazard ratio 1.01, 0.87 to 1.17, with a p-value equal to 0.93. A meta-analysis of 20 trials in 68,680 patients who received supplementation of, on average, 1.51 grams of omega fatty acids per day failed to demonstrate a decrease in total mortality, cardiac death, sudden death, myocardial infarction, or stroke. All in all, the benefits of supplementation with omega-3 fatty acids are discordant according to studies, and generally disappointing in recent clinical trials and meta-analyses. Although large numbers of patients have been included in completed trials of N3 supplementation, meta-analysis of efficacy has not been reported. Pause the video and carefully scrutinize Figure 15.6 illustrating fibrates' mechanisms of action before advancing to the next slide. We will now look at other trials with lipid intervention in diabetes mellitus patients. In the proactive randomized placebo-controlled CV outcomes trial, addition of pioglitazone, a glucose-lowering PPAR gamma agonist that has some degree of PPAR alpha agonism, versus placebo resulted in complementary improvement in lipids and lipoproteins as a result of pioglitazone's pleiotropic effects on lipid metabolism and fatty acid oxidation. In proactive, patients with type 2 diabetes mellitus patients and prevalent cardiovascular disease were randomized to receive pioglitazone, target dose 45 mg daily, versus placebo. The incidence of the primary composite outcome, such as death, myocardial infarction, stroke, unstable angina, coronary or peripheral revascularization, amputation, was not statistically different between the groups, hazard ratio 0.9, with a 95% confidence interval of 0.8 to 1.02, but the prioritized secondary outcome of death, myocardial infarction, or stroke did demonstrate superiority of pioglitazone, hazard ratio 0.84. with a 95% confidence interval of 0.72 to 0.98, with an absolute risk reduction of 3.4%, or RRR of 16%, and a 3-year number needed to treat of 29 patients. It remains unclear to what extent the lipid-modifying properties of pioglitazone have influenced these results. In the intensified multifactorial STENO-2 intervention study, which combined lipid-lowering agents, statin and/or fibrate, renin-angiotensin system blockers, aspirin, and tight glucose regulation in patients with type 2 diabetes mellitus and microalbuminuria, a significant and pronounced reduction in all-cause mortality was observed, hazard ratio 0.6, with a 95% confidence interval of 0.32 to 0.89, with a p-value equal to 0.02, amounting to an absolute risk reduction of 20%, or RRR of 40%, and a number needed to treat for 5 years of 13 patients. One must nevertheless acknowledge the limited statistical precision of these estimates, as the overall trial randomized only 160 participants, who experienced a limited total number of incident events. Furthermore, it is not possible, because of the multifactorial design, to quantify the beneficial component related to lowering of LDL-C or other lipids from those related to improvement in non-lipid risk factors. The Anglo-Danish-Dutch study of intensive treatment in people with screen-detected diabetes in primary care, Edition Europe, investigated 3,057 newly diagnosed patients with type 2 diabetes mellitus randomized to either routine care or intensive treatment of cardiovascular multiple risk factors. Despite improvement in cholesterol levels, blood pressure, and HbA1c, there was no significant reduction in cardiovascular events, hazard ratio 0.83. with a 95% confidence interval of 0.65 to 1.05, or total mortality, HR 0.91, with a 95% confidence interval of 0.69 to 1.21. Next we will discuss clinical practice guidelines for lipid-lowering therapies. Most published guidelines for lipid management advocate intensive lowering of elevated LDL-C in adult patients with hypercholesterolemia, based on therapeutic lifestyle interventions and with statin therapy as the primary pharmacologic intervention. Because of their heightened cardiovascular risk, patients with diabetes mellitus are a choice group to benefit from widespread statin use in primary or secondary cardiovascular prevention, irrespective of baseline LDL-C levels. Thus, diabetes mellitus patients without overt cardiovascular disease are often considered as having coronary heart disease risk equivalency, and on that basis the LDL-C levels to trigger statin initiation and commensurate LDL-C targets are often lower than those for non-diabetic patients. All in all, most guidelines and consensus statements from diabetes or cardiology scientific societies regarding management of dyslipidemia for patients with diabetes mellitus advocate aggressive lowering of LDL-C. In addition to therapeutic lifestyle changes, statin therapy is considered the mainstay of dyslipidemia management, ADA, European Association for the Study of Diabetes, abbreviated as EASD, European Society of Cardiology, abbreviated as ESC, European Atherosclerosis Society, abbreviated as EAS, National Cholesterol Education Program, Canadian Cardiovascular Society, ACC. We will now discuss 2011 European Society of Cardiology and European Atherosclerosis Society guidelines for the management of dyslipidemias. The 2011 ESC, EAS guidelines for the management of dyslipidemias endorse the use of the score risk estimating equation to categorize patients into risk categories, on which recommendations for lipid management are based. 4 categories based on total cardiovascular risk are listed: Patients with diabetes mellitus are, in general, at very high or high risk, especially those with type 2 diabetes mellitus. 1. Very high risk. Patients with documented cardiovascular disease, previous myocardial infarction, acute coronary syndrome, coronary revascularization and other arterial revascularization procedures, ischemic stroke, or peripheral arterial disease. Patients with diabetes mellitus plus target organ damage, e.g., microalbuminuria, patients with moderate to severe chronic kidney disease, and patients whose calculated 10-year score risk for fatal cardiovascular disease is 10% or higher. 2. High risk. Patients with markedly elevated single risk factors, e.g., familial dyslipidemias, and patients with 10-year score risk of 5% to 10%. 3. Moderate risk. Patients with 10-year score risk of 1% to 5%, with risk modulated according to family history of premature coronary artery disease, abdominal obesity, physical activity, HDL-C, triglycerides, C-reactive protein, lipoprotein A, fibrinogen, homocysteine, ApoB, and social class. 4. Low risk. Individuals with 10-year score risk below 1%. In this context, all patients at very high or high risk should be treated with medical therapy in addition to professional advice on lifestyle changes, whereas those at moderate risk should receive lifestyle advice with or without lipid-modifying medication or medications, and low-risk patients should be treated with lifestyle advice alone. The guidelines recommend pre-treatment lipid profile assessment with LDL-C as the primary focus. Triglycerides and HDL-C may be considered to complement risk assessment and to refine therapeutic choice. And ApoB measurement is recommended for better risk characterization of patients with diabetes mellitus and/or the metabolic syndrome. LDL-C is the paramount treatment target, whereas total cholesterol is an alternative treatment target if other analyses are unavailable. TGs should be monitored during treatment of patients with hypertriglyceridemia, but measurement of on-treatment HDL-C is not recommended as a therapeutic target, nor are calculations of on-treatment ApoB, ApoA1 and non-HDL-C, HDL-C ratios. Non-HDL-C is a secondary target for patients with diabetes mellitus and/or the metabolic syndrome. ApoB is also a secondary treatment target. In all type 2 diabetes mellitus patients, bringing LDL-C below 100 mg per deciliter, that is less than 2.6 millimoles per liter, is the primary target. Non-HDL-C below 130 mg per deciliter, that is less than 3.4 millimoles per liter, and overall ApoB below 100 mg per deciliter are secondary targets. Class 1 recommendation, level of evidence B. In patients with type 2 diabetes mellitus and coronary heart disease or chronic kidney disease, and in those without coronary heart disease older than 40 years with one or more other coronary heart disease risk factors or markers of target organ damage, the primary goal is to lower LDL-C to below 70 mg per deciliter, that is less than 1.8 millimoles per liter, and the secondary goals are to bring non-HDL-C to below 100 mg per deciliter, that is less than 2.6 millimoles per liter, and ApoB to below 80 mg per deciliter. This is a Class 1 recommendation. Level of evidence B. In all patients with type 1 diabetes mellitus and in the presence of microalbuminuria and renal disease, LDL-C lowering by at least 30%, with statins as first choice and eventually with a drug combination, is recommended irrespective of baseline LDL-C. This is a Class 1 recommendation. Level of evidence C. And now we will discuss 2013 European Society of Cardiology and European Association for the Study of Diabetes guidelines on diabetes, pre-diabetes, and cardiovascular diseases. The 2013 ESC guidelines on diabetes, pre-diabetes, and cardiovascular disease, developed in collaboration with the EASD, recommend classification of patients with diabetes mellitus as being at very high risk or high risk for cardiovascular disease, depending on the presence of concomitant risk factor and target organ damage. They do not recommend assessment of cardiovascular disease risk in diabetes mellitus patients based on scores developed for the general population. Estimation of urinary albumin excretion rate is indicated when risk stratification of diabetes mellitus patients is performed, whereas screening for silent myocardial ischemia may be considered in selected high-risk diabetes mellitus patients. Statin therapy is recommended for patients with type 1 diabetes mellitus and type 2 diabetes mellitus at very high risk, diabetes with at least an additional cardiovascular risk factor or target organ damage, with an LDL-C target of below 70 mg per deciliter, that is less than 1.8 millimoles per liter, or at least a 50% reduction of LDL-C when this target cannot be attained. Treatment with a statin is also recommended for patients with type 2 diabetes mellitus at high risk, with an LDL-C target of below 100 mg per deciliter, that is less than 2.6 millimoles per liter. For type 1 diabetes mellitus patients at high risk, statin use may also be considered irrespective of baseline LDL-C. A secondary goal of on-treatment non-HDL-C below 100 mg per deciliter, that is less than 2.6 millimoles per liter, may be considered in patients with DM at very high risk, and of below 130 mg per deciliter, that is less than 3.4 millimoles per liter, in patients at high risk. In addition, intensification of statin therapy should be considered before combination therapy with ezetimibe. Finally, the use of drugs that increase HDL-C levels to prevent cardiovascular disease in type 2 diabetes mellitus is not recommended. Recommendations from other major scientific associations are often consensual with respect to primary and secondary lipid and lipoprotein targets to be achieved through therapeutic lifestyle changes and lipid-lowering drugs, alone or in combination in patients with diabetes mellitus, in primary prevention or secondary prevention. And now we will discuss the 2013 American College of Cardiology and American Heart Association guidelines for the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults, Global Risk Assessment for Primary Prevention. The 2013 ACC/AHA guideline on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults, Global Risk Assessment for Primary Prevention recommends the use of the pooled cohort equations to estimate 10-year atherosclerotic cardiovascular disease risk in both white and black men and women, and to more accurately identify higher-risk individuals for statin therapy, focusing this treatment on those most likely to benefit. This guideline proposes a paradigmatic revision of the management of hypercholesterolemia, which is the subject of ongoing debate. Thus, for secondary cardiovascular prevention, with or without diabetes mellitus, high-intensity statin therapy, atorvastatin 40 to 80 mg or rosuvastatin 20 to 40 mg per day, is recommended to lower LDL-C by 50% or more on average, with combination therapy to be considered if a 50% reduction is not achieved. For patients 40 to 75 years old with type 1 diabetes mellitus or type 2 diabetes mellitus in primary prevention whose LDL-C is 70 to 189 mg per deciliter, corresponding to 1.8 to 4.9 millimoles per liter, absolute 10-year risk of atherosclerotic cardiovascular disease should be computed using the pooled cohort equations. If the calculated risk is below 7.5%, moderate intensity statin therapy is advocated: atorvastatin 10 to 20 mg, rosuvastatin 5 to 10 mg, simvastatin 20 to 40 mg, pravastatin 40 to 80 mg, lovastatin 40 mg, fluvastatin 80 mg, fluvastatin 2 by 40 mg, pitavastatin 2 to 4 mg, all daily doses, if calculated absolute risk is 7.5% or higher. High-intensity statin therapy, as defined earlier, is recommended. And now we will discuss reconciling discordance in the guidelines. Simultaneous achievement of several therapeutic targets inevitably leads to consider the pros and cons of two escalation approaches, one that involves using several lipid-lowering medications with complementary mechanisms of action, and another that advocates dose titration of monotherapy. With regard to multiple lipid target achievements in diabetes mellitus patients, the frequent joint presence of atherogenic dyslipidemia is associated with lower success in achieving recommended targets for managing hypercholesterolemia, namely, achieving targets for three modifiable risk factors: LDL-C, non-HDL-C, and ApoB. Such low achievement was found in a large proportion, 1/3, of very high-risk type 2 diabetes mellitus patients, despite very low on statin LDL-C levels. Given currently available medications, combined attainment of LDL-C, non-HDL-C, and ApoB targets will require titration or permutation of statins, reinforcement of therapeutic lifestyle changes, and/or combination lipid-lowering therapy. Thus, a lipid-lowering therapy policy solely guided by an LDL-C target may not systematically deliver synchronous attainment of all atherogenic cholesterol targets, because lipid-lowering drugs do not produce strictly proportional decreases in LDL-C, LDL-P, non-HDL-C, and ApoB. More than 90% of circulating ApoB belongs to LDL-Ps, which account for the bulk of non-HDL-C, meaning that discordant rates of achievement of targets for LDL-C versus ApoB and/or non-HDL-C hints at potential unaddressed modifiable residual cardiovascular risk. Many recommendations include evaluation of and targeting therapy toward other non-LDL components of dyslipidemia, especially raised triglycerides and/or low HDL-C in subgroups with high coronary heart disease risk once LDL-C is a target. Along these lines, the lower the on-treatment LDL-C level achieved, the more likely that all four critical variables used to assess hypercholesterolemia, LDL-C, LDL-P, non-HDL-C, and ApoB, will attain their respective targets. With regard to baseline and on-treatment non-HDL-C and ApoB levels and LDL-C, a joint consensus statement issued by the ADA and the ACC Foundation recommends two sets of triple targets for patients at high or very high cardiometabolic risk, respectively. LDL-C, non-HDL-C, and ApoB levels below 100 mg per deciliter, that is less than 2.6 millimoles per liter, below 130 mg per deciliter, less than 3.4 millimoles per liter, and below 90 mg per deciliter, respectively, are recommended for patients with diabetes mellitus but without major coronary heart disease risk factors. LDL-C, non-HDL-C, and ApoB levels below 70 mg per deciliter, less than 1.8 mmol per liter, below 100 mg per deciliter, that is less than 2.6 mmol per liter, and below 80 mg per deciliter, respectively, are recommended for patients with the highest coronary heart disease risk, that is, known coronary heart disease or DM plus one or more additional major coronary heart disease risk factors. Regarding individual components of atherogenic dyslipidemia, or the presence of atherogenic dyslipidemia in high-risk patients reaching recommended levels of LDL-C, a recent EAS consensus statement recommends for male and female patients with triglycerides of 150 mg per deciliter, that is equal to or greater than 1.7 mmol per liter, or higher, and or HDL-C below 40 mg per deciliter, less than 1 millimole per liter, the consideration of intensified LDL-C lowering, the largest decrease being reached by maximizing statin therapy and or the addition of ezetimibe, or combination of lipid-lowering therapy with niacin, although currently not marketed in Europe and the United States, or a fibrate, after intensifying therapeutic lifestyle changes, addressing secondary dyslipidemias, and checking patient compliance. Based on clinical outcome and safety data for combined statin plus fibrate therapies, fenofibrate is the preferred fibrate among the class to be added to a statin. Titration of the statin dose or use of more potent statins are options most often used when further reduction in LDL particle concentration is contemplated. Other combination therapies can also be used in selected patients, associating a statin, in addition to therapeutic lifestyle changes, with ezetimibe, niacin, or fibrates to reach all LDL-related targets. In addition, such combinatory strategies can contribute to improvement in other non-LDL features of diabetic dyslipidemia. Determining whether this will reduce coronary heart disease outcomes will require dedicated outcome studies with diabetes mellitus patients for each association. We will now look at unmet clinical needs and future directions. At present, results from trials evaluating the effects of lipid-lowering medications other than, or added to, statins on coronary heart disease outcomes have been either disappointing or inconclusive, especially when baseline LDL-C was normal or controlled with statins, with or without ezetimibe, and or whenever the annual cardiovascular event rate during follow-up was relatively low compared with older landmark trials. Regarding statins, evidence of the effectiveness of the entire class, in terms of reduction of occurrence of composite primary outcomes, is undeniable in diabetes mellitus patients. The presently unmet need for definitive proof of efficacy of current lipid-lowering drugs on all components of lipid-related coronary heart disease in patients with diabetes mellitus is attributable to a variety of causes. There have been few diabetes mellitus-specific trials. Most of the available evidence has been derived from post-hoc analyses of diabetes mellitus subgroups. Within the aggregate diabetes mellitus dataset, the relatively few cumulative events available for analyses challenge statistical power for efficacy assessments, especially for assessment of effects on individual components of the endpoints analyzed, as shown in Table 15.7. This is confounded by the inclusion in several trials of patients at lower risk than planned, resulting in low event rates and marginal statistical power, and use of suboptimal eligibility criteria in the context of the study medication being evaluated. For example, The inclusion of patients in the field or ACCORD lipid trials without requiring hypertriglyceridemia and/or atherogenic dyslipidemia remains difficult to defend, given the prevalence of atherogenic dyslipidemia in diabetes mellitus patients and the mechanism of action of the PPAR alpha agonist tested. Pause the video and carefully scrutinize Table 15.7 summarizing statin efficacy on coronary heart disease outcomes in patients with diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 15.7 summarizing statin efficacy on coronary heart disease outcomes in patients with diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 15.7 summarizing statin efficacy on coronary heart disease outcomes in patients with diabetes mellitus before advancing to the next slide. In summary, patients with diabetes mellitus, especially type 2 diabetes mellitus, are at very high risk of coronary heart disease, particularly because of the high prevalence of LDL-C and non-LDL-C dyslipidemias and other comorbidities. Large clinical trials have unambiguously demonstrated the elevated risk for coronary heart disease in diabetes mellitus, and the significant coronary heart disease risk reduction that can be achieved by statins in both primary and secondary prevention populations. With regard to other lipid-lowering medications, instead of or added to statin therapy, there are currently insufficient data to guide clinical recommendations and use, overall and in diabetes mellitus populations specifically. Therefore, support for pharmacologic treatment of diabetic dyslipidemia remains grounded on pathophysiological considerations, epidemiologic associations, and signals based on post-hoc analyses from selected clinical trials. All guidelines recognize a higher risk of coronary heart disease in patients with diabetes mellitus, even in situations of primary prevention, compared with non-diabetic patients. This recognition underlies the current recommendations, generally converging, which advocate targeting of LDL-C as the major modifiable lipid risk factor for coronary heart disease in diabetes mellitus patients, although there is ongoing debate regarding the clinical relevance of the concept of therapeutic target values for LDL-C versus matching intensity of drug with estimated cardiovascular disease risk. In addition, there remains debate about whether other therapeutic targets should be pursued, such as non-HDL-C, ApoB, triglycerides, and HDL-C in patients treated with lipid-lowering agents. The lipid-lowering effects of drugs under development make them potentially attractive to improve both standard care and other aspects of dyslipidemia management in patients with diabetes mellitus. This includes screening for and targeting the high residual vascular risk that persists in diabetes mellitus patients whose LDL-C is controlled on statins and that is present in patients with inadequate LDL-C levels, and the risk of persistently high LDL-C in patients with severe statin intolerance. The future challenge will be to identify and to bring a greater majority of patients with diabetes mellitus to meet their personalized optimal levels of LDL-C and non-LDL-C, to further reduce the occurrence of coronary heart disease. Thank you.